what is the economic benefits of this. So you're right, there's potential benefit of the NHS, but actually in education and employment. So being able to evaluate, the wider benefits of an investment like this, I think is really important. I mean, I'm in the same space as Lee. I think this is a really good piece of work for clinical support, balances, delivering a really valuable transformation for people with the financial consequences. I think Lee and I already have raised with the National Finance Director this specific issue. I do think there's something about, because we won't be the only citizen wrestling with it, and everyone in the country will be wrestling with this. I think there is a bit of a national discussion to be had around, what TAs are coming down the line, and how do we get ourselves into a position where we can actually afford them as an NHS, as opposed to they just arrive and we have to respond.
And if I remember rightly, when NICE approved the guidance in the way that they did, they were slated for delaying your financial crime. Just to be clear, they were absolutely slated. This is about 9 months ago, I can't remember. They were saying, no, if this is good, you should just say it's good and force people to do it. And the 5-year leading in was not supported by a lot of patient groups. She don't have enough with you, Jack.
Yeah, I think because we know what this is going to cost us, but I think this is a really good example of us pushing this conversation around the economic financials of it, the wider system and partners. So I'm thinking, for example, there's work happening in the mayoral combined authority about health and employment and getting people back into health. There's a real opportunity here to say, look, if we can get wider investment from our wider partners and system into this, we know what the costs are, we can present those costs to them, to say there's a real benefit, like Gavin was saying, in education, in employment, in so many different aspects. But I think it's pushing that conversation out to say, we know what it's going to cost us, we need some assistance, help, resources. It isn't just an NHS cost, because the benefits apply right across the piece. And I'm just thinking, for example, within the VCS sector, in the past, where we've had the public sector struggle leveraging in resources for programs like this, actually one of the key partners in that has been the VCF, of being able to apply for grants, trust, foundation, but also national funding that the public sector really might not be able to. So I just think there's a real opportunity to take that integration approach around the financial aspects of this. But we know what it's going to cost, we know what the implementation is. I think it's maybe just pushing that boat out a little bit and saying, we need some help, because I think whilst it's fine for us to hold the purse, sometimes it's all right for us not to hold the purse, but to get the resources in as well.
I think you're right, Gina. Let me tell you, my honest view is that, yes, this will have a wider economic benefit. We will not receive any income from anybody as a result of that. Just into the real world. And the local authorities would say, God bless them, they have enough problems of their own, which I think they have. The truth is, this will make a difference economically. I'm unconvinced that we'll receive, maybe I'm an old cynic and I am old, but I'm unconvinced we'll receive any external. You were supposed to say no at that moment. I am unconvinced that we'll receive any external support from this. And I don't want this board to make this judgment thinking that we will, because I don't think we will.
My point is, it's not about us making that judgment, it's about us putting that out.
Don't doubt that for a second. Jackie, you wanted to say?
Yeah, just in terms of the benefits quantification, I think we are trying to more systematically monitor those and make sure that we're adding those together and playing those back out into the system. I think particularly around diabetes, though, I think the expectation of emptying diabetes clinics when we forecast forward to 2030, the prevalence of type 2 diabetes.
Type 2, I was about to say.
So just because we don't see an emptying out of diabetes clinics isn't because this is a benefit. We need to be modelling where we think the utilisation is going to improve too.
I've seen that in a lot of other work too. People comfortably move forward on this basis. I mean, I think it's as good as we can do. Can I thank you all for the work that you've done? Because actually, this is a really good piece of work. Thank you very much. Just to let you know, we're significantly behind time, which you can't blame the chairman. Finance.
There are 3 things in the finance report. Just a factual update on the month 8 position. So The deficit for the system at month 8 was 47.3 million, largely 41.8 million in the ICB, 5.5 million in providers. Still relatively confident the provider position will stabilise out and get back to break even by the year end. The position did improve a bit, month 7 to month 8. Single swallow doesn't make a summer, however, so we'll see the month 9 position later on this week. The adverse position against plan, ICB 16.2 million, providers 8 million, 10.9 million is the system risk number. So that's the fabled 49 million we hold in the middle. And what are we going to do about that? Obviously, because we've been in the INI process, the investigation and intervention process, we've got a clear line of sight for this position in terms of both the regional and national team. So we're telling them where we are sort of month on month. So there is a benefit to that process just in terms of communication with the national team. What we've said to the national team is we've got quite an ambitious plan about getting to a risk mitigated year-end forecast of 36.3 million. That is not without risk, which we've expressed. There's lots of things to do to get us there, being managed through System Efficiency Board. That's a very live conversation. I was speaking with the Regional Director of Finance just about the kind of orchestration of year end at a national level yesterday, just about what does that look like. And I was talking about there's something called a forecast change protocol, which we need to go through if we were going to change our forecast and just the dynamic of that. I'll see what month 9 looks like. I'll do the flash report up to the board and then go, what do we think the most likely year-end forecast is going to be? And that then perhaps evoke that forecast change protocol at that point. There's still some things we need to do to evoke it. So we need a peer-to-peer review of the forecast, which I'd quite like to do across NEY to go, can we learn anything about what some other systems are doing? The final thing in the report then, above and beyond the year-end forecast, is just I've got the closure meeting with Deloitte tomorrow around them having concluded their work under the INI process. We no longer have an NHS England appointed system improvement lead. She is no longer in the building, but she was helping us, Rachel Hardy, in delivering this. There were 3 pieces of work really that came out of that Deloitte's engagement. One was a drivers of the deficit piece of work that we discussed in Finance and Investment Committee. One was around financial controls. They're both informing our work in the System Efficiency Board space. The third piece of work we mainly got was around, we're going to have to think of a better title, but it's sticking, isn't it? Just around the difficult choice work. To be brutally frank, we've got a list of things we know we could try and do, but we don't have is a small flotilla of people to implement that work for us. So we're going to have a bit of a conversation about 25, 26 between now and year end. How do we orientate the ICB resource towards some of that difficult choice work? Because candidly, generating a list doesn't generate savings. Generating a work plan and putting people behind it generates savings. And I think given what we know about 25, 26, I've said previously, I thought we were going to have to do some sophisticated calculus about which difficult choice work we're going to have to implement. I think the reality will be we're going to have to implement most, if not all of it, sensible prioritised pace. So more work to follow there in the executive side of the street. 3 things for the board for now. Month 8, we know where we are. We'll look at month 9 when we get it. Perhaps evoke the forecast change protocol once we see the month 10 number, because I need to do a bit more staff work before we can do that. NHS England are well appraised of our position in terms of where we're trying to get to by year end, 36.3 million. And we've concluded the Deloitte's work, but that doesn't invalidate challenges we've received from independent non-executive members just about our capacity to do transformation and change around here, when we know looking into next year, it's probably going to be even bigger. I think that's enough for the public space.
Okay, we've got a session later in the fall.
Yeah.
Can I just check? This is me making sure I am clear in my very simple. When we talk about 36 million, that's 36 million worse than the 48 we expected.
36 million total. So we're saying we might be able to put mitigation in place which gets the INU position and improves it between now and the year end.
Yeah.
So that would be a 36 million pound deficit, bottom line across the whole system. Very, very challenging.
Any questions? We've got a session later. Let's leave that for the session later. That's okay, guys. Thank you. We thank you, Specialist Commissioning. Verbal update?
Absolutely. There is a Audit Committee Chairs meeting later on the month, which will describe where we've got to in
Audit Committee Chairs
across the NEY.
Sorry,
across NEY.
Yeah.
So we've
It's a jolly bunch.
Yeah, I can imagine. There's a group. There's a group of which I can't.
And it's all relative. It's all relative.
That's an adjective, certainly, Kevin. So there's a group of audit committee chairs that are grouping together to do some oversight around what's going on with specialist commissioning delegation. We've run 3 workshops across NEY about how we're going to do this thing. We are still looking at South Yorkshire hosting the staff who will transfer under Cheapy on the 1st of July is currently the plan.
Okay, so
we will take responsibility for specialist services commissioning delegation on the 1st of April. That's been approved by NHS England, but there is loads of work still to do about making all of that happen. We're about to stand up the shadow oversight arrangements for specialist commissioning, both devolved and non-devolved. It's a bit in terms of how it's managed over the next 3 months, which will particularly face into what's going on with the planning environment. I've described elsewhere, there's 3 risks we're managing really. There's how we get the existing risk management arrangements to work from the core ICB's perspective, in terms of the existing specialist commissioning oversight. How do we understand the risks in our service delivery? There's then a series of risks that we're managing around the transfer itself. So can we develop a safe landing? But I'm particularly keen on the 3rd basket of risks, which is how are we managing the risks associated with delivering the benefits that were proposed around delegation? Because candidly, if we just lift and shift it, we're slightly missing the point about how do we sensibly orientate the specialist commissioning resource towards doing more transformational work with the ICB service portfolio and engaging differently with provision is why we're fundamentally doing this. But there's a balance in that about it's still the same team that will be doing broadly the same job. And they're obviously quite nervous about, we can't do 2 jobs. We're responding to a sort of national mandate and regionally how we've conducted this thing. But increasingly we'll get into what's the service change we can expect beyond this. But we're managing those risks slightly sequentially because I can't think of a better way to do it. So more formal updates before we formally receive the services, but Kevin's involved in this, trying to keep me honest in terms of managing those risks, which are not insubstantial.
okay, thank you. Kevin, you're comfortable with that?
Yeah, nothing to add. I gave an update at our last public board meeting following our last audit committees. And we were satisfied. Okay, along the lines that we had. Nothing to add.
Thank you. Corporate assurance and ICB governance items, Mark.
Thank
you, isn't it? Yeah.
It is, thank you, Chair. And I note that there are a large number of documents in this meeting. So there are a considerable number of items for consideration and approval. I would like to thank a number of people across the organisation for a lot of work that is belied by the summary paper, but particularly Ruth Brown, who's here, and Calvin Call for speed and because of the time of we are in terms of the agenda, Chair. Can I suggest that we move immediately to the recommendations? And I'll just work through the recommendations as the way through. So firstly, I can ask the board to consider and note the corporate assurance report and duties that have been undertaken throughout the period since the last meeting. Moving to Annex A, I would ask the board in response to imminent changes to the responsible officer regulations, the ICB is required to have an RO and is also therefore required to take on the status of the designated body. So I would ask the board to consider the nomination of Dr. Crichton as who is our CMO, to the role of responsible officer, and to recommend that the board take on the status of designated body and then make the necessary arrangements and recommendations to the GMC. We then move on to Annex B, note the key items of the business insurance committees of the board. Annex C, ask the board to ratify the 3 policies and procedures that have been through due process. They are the adverse weather plan, business continuity policy and plan, and the emergency preparedness resilience and response policy. They've all been through due process and are recommended to the board for ratification. Ask the board to note the inspired colleagues plan, which is set out in Annex D. We're halfway there. I'm doing okay. So,
Doing well.
Yeah,
You're doing well.
Thank you very much. A really significant item, I asked the board to consider and recommend to NHS England the proposed changes to the ICB's constitution that reflect the significant discussion that taken place in September last year. The summary changes are set out within the documentation at agenda item 19.1 and section 3 papers.
I ask the board to consider approving the proposed changes to the ICB scheme reservation delegation, which is linked to the changes to the Constitution. To consider and approve minor changes to the ICB standing financial instructions and the revised operational scheme delegation as specified the allocated finance officer. Finally, to consider and approve the proposed changes to the audit risk committee's. So if I can just conclude, they are the 9 items that was best considered in the note.
People comfortable for the appointments. I've got to make a deputy chair, senior independent. Following this, I talk separately to the independent non-execs. We will formalise those appointments to be formally agreed in March. Just so people comfortable with that? Thank you. I think you did that with a remarkable brevity. It's becoming a requirement. EPRR course standards. Is that you now? It is you now. Yeah, you inherited this. I remember the previous post will be giving it away with some joy if I remember. Did he not?
Absolutely. So I will be even briefer than Mark in terms of this behaviour here. So as everybody knows, we are, as an ICB, we need to do an annual assessment against the EPR standards. Yep. This time last year, we ratified a 17% compliance with the standards. We have gone through the process this year, and our compliance as an internal assessment is at 50%. That, as you can see, puts us in the pack with our other ICBs across the patch, and has been through the audit and risk committee in terms of ratification. The challenge for us will be next year in terms of the step up from 50, and Kevin gave me a healthy challenge in terms of where do we think we'll be this time next year. I need to manage expectations in that respect, because there are some big pieces of work we've got to do as an ICB around one, training, and that is one, training up our managers, but two, actually having the training available for people to do, which is a challenge, and that's a regional challenge. And then two, our business continuity, which is not where it needs to be as an ICB. So we have got packages of work that we've kicked off. We will feed into the audit risk committee. I think it will be next year, and we're just doing that assessment against our work plan. So what I'd ask today, the committee signs off the 50% in terms of our assessment.
And you're happy with that as an accurate assessment?
Yeah, and Sarah did manage expectations of our progress over the next 2 years, and they were fully understood. So happy with that. Just under our journey to full compliance, which will probably take at least 2 years. But in terms of sign off, it's central.
Thank you. Thank you. Sarah, thank you. People comfortable with that? PTS eligibility criteria.
So back to me here. So this is another fairly meaty topic, but hopefully there was a national review undertaken. So non-emergency patient transport services we rely on a daily basis to assist people to get to appointments, to discharge people from hospital. As a national, and I should welcome Leslie Carver, one of the program managers for urgent emergency care. There was a national review in 2019. The outcome of that was there was a publication by NHS England that defined some standard eligibility criteria, and there was an ask for ICBs to implement this. The overarching principle of that is that in the first instance, patients who are able to get to hospital on their own do so. But within the criteria, it does lay out quite a number of eligibility criteria, which covers things like medical, cognitive, sensory impairment, safeguarding considerations, wider mobility needs. But actually, when you look at it, it is quite broad. We've seen over the past years a year-on-year increase in utilisation of patient transport services, and that continues as well. I think we need to recognise under the current significant financial pressures we're in that we do make these services available for those who need it most. Within the guidance, it also talks about alternatives such as healthcare, travel costs, schemes, and they are a way of mitigating against where finances drive the rationale behind people wishing to become eligible. I say I might bring you in here because we've got quite a big pack. You and I, alongside Yaz and the engagement team, have been to JOS, and we've got health inequality impact assessment, which is pending as well. So Leslie, can I bring you at this stage?
You can. Thank you, David. Good afternoon, everyone. I'm just going to quickly run through some of the key themes. I'm hoping you can hear me because I can't see myself.
We can.
Excellent. Thank you. So when we were looking at the eligibility criteria, we wanted to identify the key potential risks that we thought for our South Yorkshire population. We identified two key risks. One, that more individuals across South Yorkshire would be ineligible for the NEPS service, resulting in more individuals missing or facing delays in their secondary care treatment. And then the second risk was around the impact on individuals and communities across South Yorkshire having the means of independent travel, again resulting in individuals from disadvantaged and unrepresented communities missing or facing delays in their secondary care treatment. As part of the understanding the impact of the risk for our South Yorkshire patients, we carried out the following work. So we did a South Yorkshire local impact assessment to help us identify the individuals and the changes and the impact that it would have on people. And we looked at groups of populations and individuals that could experience the greatest impacts, how many individuals the changes to the standard criteria could impact on, and also the groups and populations of individuals that could experience the greatest impacts. I'm going to give you a brief summary of the key findings, but the full findings are in Appendix B within the papers. So we know that approximately 27,000 individuals, so 2% of the South Yorkshire population in South Yorkshire, accessed the non-eligibility PTS service in 23-24. It's anticipated that the new criteria will impact on those patients currently identified as requiring standard/saloon car or W1, which is wheelchair users requiring no additional assistance. In total, there were 78,130 journeys for people using the standard car/salon or wheelchair users that are likely to be impacted by the new policy. Deprivation was a significant factor in the use of services, where 45% of our patients accessing NEPS live in the most deprived areas of South Yorkshire, whereas only 6% live in the least deprived areas. We believe that the impact will be on our older population, given the majority of people accessing the service are aged 66 or above. So 68% of journeys are for people in this age bracket. It's also notable that users in the most deprived areas were younger than in the least deprived areas, reflecting the higher levels of poorer communities using the service. We noted with regard to children that although the numbers are low for children and young people, over 76% of journeys in the age band were from the most deprived areas, suggesting that children from the most deprived areas are more impacted than other groups. Men were slightly more impacted as well, and the pattern of service for ethnicity was representative of the general population. So 87% of service users were white, which is the same as the proportion in the general population. We then undertook with our ICB engagement team public involvement work, and this took place between the 22nd of July and the 2nd of September for 6 weeks, and full information about that is in Appendix F. Feedback from the patients can be found in Appendix C. We had 56 responses to the questionnaire that was sent out. And some of the key themes were about how important it is for people to be able to access their appointments, that the impact on family and friends who already have busy lives, people with disabilities and health conditions felt they required specialist support and escorts to attend hospital. It was felt that criteria can sometimes be open to interpretation, and it was felt that the changes could significantly affect people's health. When we looked at further support that was required from the public involvement piece, people felt that more support for people with disabilities, mobility needs and older people to access transport should be in place. Consideration of individuals' needs, improvement to public and other alternative transport, parking arrangements at hospitals, including maps, public transport, social care services and hospitals to work together so that appointments can be arranged where individuals can be supported. Escorts was really a key theme that came through, and also not to have to repeat needs for people who use the service often. We also engaged additionally with the 4 health watchers across South Yorkshire, and they provided a joint response, and I've just pulled out the key themes with regard to that. Travelling difficulties to medical appointments across South Yorkshire is a trend all regional health watch hear about, especially since the cost of living crisis started. They felt that there were fewer buses, that people were struggling to have the money to claim reimbursements via the hospital, resulting in people not receiving essential treatment at their hospital appointments. And also rural places we serve have only 2 buses a day. That was also a comment. The recommendations from Health Watch align to the work that we're looking at with regard to our mitigations. So providing clear information about the criteria, having a clear process for people to have an appeals process, work with local providers of public transport to ensure that they're taking the widest possible interpretation of the needs, routinely and consistently sharing information about how to claim back travel expenses, to monitor impact, flagging the impact of the changes at a national level where possible. There was an EQIA that has been completed for South Yorkshire, and it went to the impact assessment review on the 30th of October. The panel felt that the EQIA was a fair reflection on the possible impact to our South Yorkshire patients, and this can be found in Appendix H. The mitigations that we're looking at putting in place to be able to support our patients is to look at community transport alternatives and the use of the healthcare travel cost scheme, which is where patients can claim back their expenses via the hospital. Together with Yorkshire and Humber, other ICBs, we have worked together to submit a bid for phase 3 of the NEPS Pathfinder project, which has a particular focus on improving how people access healthcare travel cost schemes. In addition to the bid, we are working with the South Yorkshire Mayoral Combined Authority because they are undertaking a bus reform consultation currently. We're doing a targeted comms campaign to ensure patients and providers are aware of the changes and where support is available. We're in the process of working with West Yorkshire and Humber and North Yorkshire on a robust appeals process that would give patients the chance to be able to appeal if needed, and a stock take of our community transport alternatives that would be available to people when they do not fit the criteria. We're also looking at reviewing impact once the new criteria has been implemented. So looking at potential rates of DNA rates for appointments and whether that is having an impact because of the new criteria that will be coming in. We did go to the South Yorkshire, Derbyshire and Nottinghamshire joint overview and health scrutiny on the 10th of October. And we were asked to consider the following, which I think confirms the themes and mitigations that we're looking at. So access to public transport, people's income and expenditure, communications out to people, the use of reduced bus passes, consider individual cases, viable alternatives for people for community transport, and to link into the transport work, which is underway with the Mayor. We've been asked to go back to Josh in 6 months' time, so that will be in February, to give an update on the implementation work that has taken place so far. I'll pass back to David now.
Thanks, Leslie.
Thank you, Leslie.
So there was one additional piece prompt from the JOSC, and that was about actually people not being invited to hospital when they don't need to be there. And I think it nicely connects to broader pieces of work about elective transformation programs where we utilise telephones, we utilise patient-initiated follow-up, consultations. So, to be digitally minded, digital inclusion minded, but actually there's a survey being done nationally that showed that a third of people didn't know why they were going back to their appointment, a third of clinicians didn't know why they were there. So that led a third of people who genuinely, the doctor and the patient both knew why they were being attended. So before we, start arguing about patient transport services, if we're reducing the number of, travel attendance, that would be beneficial for all. As you said, Leslie, we've committed to go back to JOSC and feedback with them. So on the face of it, obviously this is something that looks like we're taking something away, but I would advocate and propose to the board that standardisation, not just in South Yorkshire but across our footprint where we depend on a single provider, predominantly as in this, is a good thing for people to have uniformity and fairness. Obviously the ask for the board today is that we support this to be implemented in April alongside the other local ICBs.
Thank David and Leslie. So in terms of the joint review and scrutiny, when we engage with those, particularly to make sure we follow due process, consulted as appropriate, whatever word that is, engage as appropriate. So what was the feedback from the JOSC that we had followed due process, David?
So I think they were generally supportive, weren't they, Leslie? I think it was an open conversation. I think we took on board their feedback and said the committee to go about it. Yes, absolutely, Chris.
So the reason I raised that is this is an area where it is quite a competitive area, so the chance of legal challenges is high. It's really reassuring to hear that.
Thank you. Lucy, you wanted to come in?
Yeah, thank you. I suppose I just wanted to sort of highlight really from a patient perspective, nobody currently opts to use this transport for more convenience. Generally, the feedback I get is that it can be quite a challenging service for people to use. So I think just to start, as you have done, with a sort of understanding that there is a real need for a lot of people, whether that is around medical need or whether it's influenced by cost is another question, but the people opting to use it currently are doing so for real, genuine reasons. So the need to understand the choices that people are sort of pushed to make as a result of any changes is really, really important. So it's just a thing really from our perspective that we keep a close eye on this in terms of impact, and everything reflected and committed to in the paper. The stuff around the healthcare travel cost scheme is really good to see as well. That's a really important bit of work that goes alongside this. I will say there's some low-hanging fruit, I think, to be had there in terms of how well that scheme is shared. Information about that scheme is shared with the public. I think we've observed in a number of our reports that it's not always easily available. People don't know about it. So there's some quite immediate things I think that could be done to promote understanding and use of that scheme, and we'll be happy from a Health Watch perspective to support you in any sort of aspect of that.
Thank you. Ben?
Yeah, just a couple of points. So I think, really good to see the work that's been done on this and the policy angle on it as well. I guess it's not a scheme that's designed to deal with cost of living and the cost of transport. I guess that's going to make sure their own scheme that.
Unfortunately, the change in the minimum pricing of bus fares increased on the 1st of January. So that's happened subsequently since we've sort of discussed this.
Yeah, so there's that. I think the other bit around it's come to and it's hard actually doing some policy really worth following up on what they're learning from that. And the other ones that will combine.
Yeah.
There's probably one additional thing, if the landscape is changing, is one of the shifts within the 10-year plan is care in the community. So it's moving from hospital to community care. I think the usage of community diagnostic hubs in town centres hopefully will be another positive to the way that we provide healthcare will be different. And it'll be more in the community. So we talked about neighbourhoods earlier on today as well. So I think this is a point in time. We hope that those changes that will happen within our infrastructure and how we provide services will also help mitigate against some of the concerns that have been raised.
Okay, that's a really good piece of work. It's really difficult given where we are today, but I think we've got great little option given that this consistency across the piece. Getting comfortable with that?
Chair, but yeah, I'm comfortable. I'm just a little nervous. I think all the right things have been recommended. My nervousness is in the very short term in the transition from the current system in that our systems, our hospital systems and primary care systems are not sensitive enough to understand that a patient's suddenly not in the system. And so I do have this niggle about what more can we be doing in the very short term, because as the system gets used to this, it will be a different outcome, that we don't unwittingly lose patients that do need the care that they're being appointed to. And I'm just worried that we'll lose people and they may come to harm. I don't know what the answer is. I just wanted to express a nervousness and somehow can we sensitise this? And so the DNA rates we can monitor, but that will tell us nothing about whether we've lost somebody. And I'd also let some thought can be put to that. But that's my only.
Well, if we agree today, we've got 3 months to think about the implementation of that, how we might monitor that. That's a reasonable challenge.
That's fair. Kevin, thank you. On that basis, happy to go forward. Thank you.
Thank you.
Item 22, workforce strategy. Bridget, you're here because Christine isn't. Nice to see you.
So this has been presented several times already. So I think probably might have already seen it. I wasn't sure if I was going to go slides anymore, to be honest, because of the time. We've got enclosure 22, page 491. It's where it is in the pack. I think in general, what the workforce strategy is, we've been working on this since 2023. We've got a couple of concepts that we've been working alongside developing it. Over 10,000 people were to get feedback on this in a range of different formats. And we launched that this year. And obviously now we need to get that signed off. We're presenting it at the South Yorkshire Integrated Care Partnership meeting on the 30th of January. And as I said, been presented and is going to be presented at many other forums. The whole workforce strategy is really designed to support the board ambition of the South Yorkshire ICT strategy, and it's all about valuing and support our entire workforce, but recognizing who our workforce. So a lot of us thinking the workforce, but there are more people around the person and the care of the person that we don't usually consider they are the workforce. They themselves don't consider themselves to be workforce. So like the volunteers, the paid and unpaid volunteers, learners, students. So the whole thing about the pathway, and you'll see that it looks like some stepping stones, but we've been going through that in the last 3 years. I think there's going to be a few other concepts coming forward, which I think the next item on the agenda will be one of them where we'll be actually putting that in place. But 2 others that we've tried, and it's hard trying to get the right people in the meetings, in the projects. And I think the biggest ask is to make sure that we need to start thinking differently and make sure the right people are there that we don't traditionally have there as well. We've got 320,000 people who are workforce working in paid and unpaid in health and care roles across South Yorkshire. A lot of people have got more than one role. So it's not just one role. A lot of us probably around this room have more than one role as well. So we need to consider that for the sake of the patients and thinking. And there are some, I'm not going to go into all of this in detail, but there are certain key things that we'll be looking at in year 1, year 2, and year 3. There's the 2 concepts that a lot of you would have heard of that we've tested this out is the health and wellbeing strategy, the 3-year roadmap, where we consulted with 50,000 people, and we started that in April 24. And that initially developing that was challenging, but we put in place that everything we do, we are following the roadmap on making sure the right people are there across all sectors and workforce. And the other one is the South Yorkshire career website. And that was launched later on in 2024 under the management of Claire Clark in the Workforce Hub. And again, that now involves all sectors in there. Absolutely a fabulous website encompassing all sectors. So the strategies here just to be noted, and obviously I don't know if we've got any questions from this as well. I wanted to keep it short and sweet. It's been I promise Mark I would. It's been delivered several times, so unless anybody's got any questions on that, I won't actually.
Bridget, thank you. It was really
Is
helpful.
that okay?
Yeah, it was grand. Grand. Any points or questions? Wendy?
Yeah, there's just something about strategy, our system strategies and the adoption of them, making sure that all of our executive leaders across our partnership are adopting them and they're implementing them. I think I've made that point. This has been nowhere near our council, if I'm really honest. So I played my part and said to our director of people, this is coming into the ICP, it's a system strategy. Can we play it out through our local authority, or be really clear about what our role is to place into this? Now it connects into our people plan as a council, and it hasn't doesn't feel as if it's connected. So there's just something about checking in, part of that ongoing
Absolutely.
Okay, really good point. Can we pick that up?
Yes,
That's it's a really good point. Because this is health and care in its very broadest sense. And those 300,000 you identified, Bridget, are local, they're a quarter of the people around here. Okay, Bridget, thank you. You want to talk about economic activity?
Well, I'll be brief, Chris. I've mentioned it already as part of my introduction, so just a couple of words. So Brigitte has just talked about the four-fold ambition around the whole workforce in health and care. This is the third bold ambition, which is the relationship between work and health. As I mentioned in my report this morning, South Yorkshire's been identified in response to the government white paper Get Britain Working as one of the three national trailblazers to look at how do we increase economic participation. So in terms of the objectives, there are about 900,000 people who are kind of adults who are eligible to work within South Yorkshire. About 25% of that cohort are not economically active, and that's so the national average is about 20%, so 25% in South Yorkshire. It's a particular problem here. Interestingly, about a third of those people who are eligible to work or economically inactive are inactive because of health-related issues around caring responsibilities or their own health condition. So it's a joint piece of work being led by Department of Health and Social Care and the Department of Work and Pensions. We've received about £80 million worth of funding, so 10 million related to the Trailblazer, which is more broad in its scope, and 8 million related to something called the Health and Growth Accelerator, which is specifically this issue around how do you support people to either access work or stay in work who have a health condition. So the aim is, over the next 5 years, to support around 40,000 additional people into paid work across South Yorkshire, and to reduce that percentage of economically inactive people from 25% down to 20%. So just before Christmas, we submitted a detailed delivery plan to the two government departments, and that's been developed jointly by ourselves, working closely with Simca, and we put in place a set of combined integrated program arrangements, governance and leadership in order to deliver that piece of work. So it's massively exciting. I think it builds on some of the good stuff that's happened already. So Barnsley Pathways, for example, and in essence, this is the Barnsley Pathways writ large. So I think it's incredibly exciting. It's good that we've secured this. There's a heck of a lot of work to do, and we're just starting. And of course, we'll program in updates as we go. But that was
just one thing, really helpful. It's great news. We look forward to it. I guess the thing that we we need to think about in relates to the devolution is this is how we manage this jointly with the mayoralty and how we report. Just something we, as a board and the mayoralty, just need to give some thought to. Yeah, because I think there'll be more of this. So we need to find a slick way of agreeing accountability and reporting rate between us and the mayoralty. And you're right. If we get this right, it will be the first of many. So we really do need to give some thought. It's a process issue, but important one, where I don't want where it's over-reported within an inch of its life, where nobody knows what's going on. We need to have something between the two, where both boards can say that feels fine. I think that's something we should just work on over the next few months with the mayoralty. People comfortable with that? Thank you. And really, really important good news. And you know, we talked before. One of the difference on health inequalities, jobs might be the biggest way into it. Okay, then there's a number of items for information. Is anybody, if any chair or someone wants to raise something, they're entitled to do it, but my eyebrow will be raised. I'll take the silence as it says. We have got a small private agenda item. Before we do that, can I say this is definitely Wendy's last meeting? So we'll all have a chance on a separate occasion to say thank you to her. But I work, but also in her presence, which I know I've enjoyed. It's also likely to be Ben's last meeting, because Ben is moving on, and you will know. So I'd just like to thank you both for your impact here. We didn't deliberately put you next to each other. But genuinely, and I thank you both for the impact you've made on this board. It's been great. It's a delight to have you here. And good luck in the future. Right, and we've got a second part formal meeting. Can we take 5 minutes break before we do that? What?